All right. Well, welcome everyone to our SIRC Health Equity Lecture Series. Today we have Dr. Stephanie Marita Carpenter, who is an assistant professor in the ASU College of Health Solutions. She is a social psychologist and decision scientist. She studies the impact of contextual and emotional factors on health behaviors using precision health methods that adapt to the unique needs of the individual. Most of her research is concerned with investigating ways to promote health equity through the optimization of strategies that increase intervention engagement. So please help me welcome Dr. Carpenter, and I'm excited for your talk today. Oh, and sorry, before you start, we will let Dr. Carpenter present for 45 minutes, and then we'll do a Q&A session at the end. So feel free when we get there to put your questions in the chat. I'm happy to read them, or take yourself off mute, raise your hand, and ask away. Okay, now I'm going to turn it over to you.
All right, sounds good. Thank you so much. I'm really excited to be here to talk to this group today. So I'm going to talk to you, as Stephanie mentioned, about how we can basically optimize strategies to promote engagement in adaptive health behavior change intervention. So my science is all around this notion of engagement. And so I'm actually going to be talking about a couple of very different projects. They seem very different from each other, but the thing that that unites them or unifies them is this concept of engagement and sort of the science around engagement. So let's get started with the roadmap here. So what I'm going to first talk about is how we can enhance health behavior change through promoting engagement. And I'm going to define engagement in just a moment. And I'm going to talk about how we can build effective just-in-time adaptive interventions in order to better promote engagement. And I'll talk about what just-in-time adaptive interventions are. And then I'll talk about some strategies that we can actually use to promote engagement using a couple different examples. So I said I'll talk about some projects that seem a little bit different from each other to give you a little bit of a sense of the broad range of research that I do. I'll talk briefly about an alcohol use prevention intervention that I developed and tested, as well as an oral self-care intervention. And then I'll talk about some other ongoing projects that I'm also involved with. So first off, I wanted to define engagement because engagement can be one of those kind of loaded terms, loaded concepts. And when we think about engagement, it's really important to think about this notion of, well, engagement with what? Because we can engage with, for example, a stimulus. So this might be a text message prompt that might come to your phone. Let's say it's in a digital or mobile health type of intervention, but it can also be for a task. So let's say you get a prompt to your cell phone to go for a walk. So the stimulus is the text message, but then you might actually get up and go for that walk. And because of the fact that engagement can be so complex, we really want to think about it as this multifaceted construct. And when I think about engagement, I really think about it as this process that involves the investment of multiple types of energies. One type of energy is affective. So as Stephanie mentioned, one of the things that I really look at is emotions and moods and affect. So we have this affective or emotional component that underlies this construct of engagement, but we also have the cognitive investment. So this is going to be things like your selective attention toward a task, as well as your attention sort of and your processing of task-related information. And then there's going to be the actual physical investment of actually getting up and doing a task, performing a task, following through with that task. So I'm just going to give a really brief example here. So let's imagine you're in a mobile health intervention, and it's an intervention where you might receive a prompt to your smartphone to go for a walk. So you'll see something like this: consider taking a 5-minute walk. When we think about these investments of these different energies, as affective, cognitive, and physical, it might play out something like this. So let's say you have a positive affective reaction to this prompt. So when you, and not only that, but you've read and you've understood it. So you understand that it's encouraging you to go for this walk. And now you're going to get up and go for a walk because it's actually a beautiful day out and you want to take advantage of the nice weather. If you weren't engaged, we might see a different process. So we might see that either you don't read or process the prompt properly, or we might see that you don't have an affective reaction to it, or maybe you even have a negative affective reaction to the idea of going for a walk because maybe it's actually very hot outside. And then the outcome of that would be, of course, that you do not go for a walk. So that's how these types of energies interplay with each other to impact whether or not we perform a different kind of task. And I mentioned that my research program is really on this concept of engagement. And so I look at how our affective processes impact when and to what extent we engage, as well as the different cognitive processes that might be impacting how we engage. But I also look at how we can identify strategies and leverage adaptive interventions in order to promote engagement. And so this is my entire program of research that's focused on this concept of engagement. So the goals of this program are really to prevent health compromising behaviors. So alcohol misuse, poor oral self-care. I'm using these as examples because that's what I'll talk about today. But I look at a number of different other types of health compromising behaviors, and I'll mention those at the end of the talk. And so these will be associated in particular with risk of disease and disability. Another goal of my research program is to promote health equity by identifying not only when, but also for whom different types of engagement strategies are going to be most effective. And so this really gets to this idea that we want to personalize these different types of strategies in order to really promote engagement. And also identifying the emotional and cognitive conditions that might help us predict if and when different people are more or less likely to engage. So I gave an example of a mobile health or technology-based intervention. A lot of the work that I do is technology-based. And so mobile and wireless technology in particular, like emails and text messages or wearable devices, they provide an opportunity for us to intervene in real-time, real-world situations. So they can allow us to collect ecological momentary assessment or EMA data. Some disciplines call this experience sampling data, which are going to be these brief surveys that are sent to our that are sent to our devices to collect information on contextual information, emotional information. Mobile and wireless technology also allows us to deliver interventions to help support our self-regulation or behavior change in real-time, real-world settings. It can also help with reducing health disparities by providing convenience and accessibility to underrepresented populations who might otherwise not participate in highly intensive interventions or may actually not have access to different types of interventions. However, despite all this promise in these sort of technology-based mobile health types of interventions, we really see low engagement. So people might start off being really excited about this intervention that's coming through their cell phone initially, but eventually we see this engagement declining, and often this decline happens rapidly over time. And so if we really want to develop interventions that people are not just excited to start using, but will actually use over time, we really need to think about how we can enhance engagement. And we can enhance behavior change by delivering intervention prompts in moments when people are likely to be engaged, right? So opportunities for engagement. So we don't want to send a text message to somebody's phone, encouraging them to go for a walk outside if it's pouring down rain. We also want to think about ways to personalize our interventions based on the internal states of the emotions people are feeling, how fatigued they are, how many cognitive resources are available to them, as well as the external context, the time of day, are they in a meeting, is it raining outside, all of these different things, as well as individual characteristics. So let's talk about just-in-time adaptive interventions and how just-in-time adaptive interventions can actually help us reach people in the moments when not only do they need an intervention most, but in the moments when there are actually opportunities for them to engage with the interventions. So just-in-time adaptive interventions, which we call JEDIs, this is an intervention design. And this design uses technology. And so this is oftentimes why we see JEDIs being employed through mobile health means, through mobile health types of interventions. They use technology to sense or collect in the moment data on the individual's both internal and external context. So we're able to actually sense what people are doing in the environment that they're in those moments. And then this in the moment data can be used to adapt the delivery of these different types of prompts in moments when engagement in a task like going for a walk is going to be more likely. So let's do a brief example of what an mHealth Jedi might look like. So imagine an mHealth Jedi that delivers prompts to young adults who are at risk of binge drinking. Okay, so I mentioned that this was one of the prevention of alcohol use, prevention of alcohol misuse, in particular of binge drinking and high intensity in drinking, is one of the areas in which I have conducted research. So as an example here, so let's imagine this mHealth Jedi is going to recommend engagement in different types of self-regulation activities that are going to help people manage, for example, stress. So we're going to recommend that on the days when risk for binge drinking is high. Maybe there's a party coming up that day where there will be a lot of alcohol at. And the purpose of this is to help reduce the likelihood of binge drinking. But in order to effectively deliver these strategies, we actually need to know under what conditions it's best to intervene. So in order to construct these JEDIs, we need to include these personal factors. And I mentioned this a little bit already, but we're going to have these internal momentary states and these internal contextual factors. But we also want to think about enduring states, okay? So not only about how your feelings or how fatigued you are in the moment might be impacting things, or where you're at in space and time and how that's impacting things, but we also want to think about enduring states like your depression, or states of anxiety that are enduring, or chronic stress that might be impacting how people are approaching different types of interventions. We also want to think about sociodemographic characteristics like race, ethnicity, gender, age, sexual orientation, socioeconomic status, and so on. And we can integrate all of this kind of information to help us understand when and for whom different types of interventions are best. So how can we identify these factors? We can conduct field experiments. We can conduct these experimental studies that will help us determine what factors and strategies will best promote engagement. And then from these studies, we can actually develop effective JEDIs. So let's talk about one of the micro-randomized trials that I have conducted to completion and published. And so this one, we were specifically looking to identify engagement strategies to promote self-monitoring of alcohol use. So we use the micro-randomized design, micro-randomized trial design in this study. So what is a MRT? So this is an experimental study design that we use to optimize a JEDI. And in micro-randomized trials, participants are randomized at each point in time. So for example, every evening, when it might be appropriate to deliver an intervention option, like a self-regulatory prompt to self-monitor how much alcohol you have consumed. So randomizations may occur multiple times per day or week or bi-weekly. It depends on your question of interest. So for example, if it's a smoking cessation intervention and you're expecting cravings to fluctuate frequently throughout the day, you might actually want to randomize people to different intervention options multiple times a day, like maybe every couple hours. If it's something more like preventing binge drinking, maybe it only makes sense to do weekly or bi-weekly in moments when a particular person might be in particular high-risk situation for engaging in high-intensity alcohol use. So MRTs can help researchers identify these conditions when it's best to deliver these different types of prompts, okay? Okay, and then we can use this information to construct our JEDI. So in this particular